Good afternoon and welcome. We are so pleased you joined us for the Healthcare Reform for the People, a conversation with former Canadian Health Minister Dr. Jane Philpott. I'm Margaret Kruk, a professor of health systems here at the Harvard School of Public Health in the Department of Global Health and Population. And I'm also a former family physician who practiced in Northern Canada, so I have more than the usual amount of interest in this conversation today. I am so delighted to be joined by Dr. Philpott, who's Dean of the Faculty of Health Sciences and Director of the School of Medicine at Queen's University in Kingston, Ontario, Canada, and former Health Minister for Canada. Welcome.
Thank you for having me.
Before we get into policy, let's talk about leadership. I've heard you speak about daring leadership. I'm curious, what is that?
Daring leadership. So I would say that it is a concept that we need more than ever. You know, you can't answer a question like that right now in the fall of 2023 in the global context in which we're existing without realizing that leadership matters and that many of those who have not stepped up for leadership actually need to be daring and step up. You know, many of the greatest crises that we're facing are related to either a lack of leadership or the wrong kind of leadership. And so when I talk about daring leadership, I talk about people who aren't there now stepping up and saying, that's not the kind of world I want to live in. I think that we can do better. I think we can be better. I think I could help. And I'm going to dare to put up my hand and say that I can be part of it. You know, I'm looking at this group here and young people, a tremendous diversity of perspectives, I assume, from this group, lots of women. Those are the people that are not necessarily getting into the positions of actually changing the way societies and cultures and countries are structured. And I want those people to dare to step up and to say, what can I do to help? How can I make things better?
And your career has exemplified that, right? Coming from medicine to the political sphere. Can you just share a little bit of that path with the group here?
Well, I don't think that this group is unfamiliar with the links between medicine and politics. We all know that, you know, we like to quote Rudolf Virchow and the fact that politics is nothing but medicine writ large. But in fact, the reason that I ended up in politics was because of my commitment to health and health equity, and the realization that the levers for actually determining who is sick and who is well are often political. And I was encouraged by particularly a former Prime Minister of Canada, Paul Martin, who said, you know, if you can get yourself around the cabinet table, you can do more to make people healthy in 10 minutes than you might in 10 years of your work in the health field. So I'm hoping some of the folks in the audience are thinking about getting themselves into a position where they can actually make those big societal structural changes.
Wonderful. You're not all to leave healthcare for politics,
not
but some of you may want to consider, because I think you're absolutely right. It all starts with the politics and also the governance. And that brings us into policy. So first of all, here we are in the US. You're Canadian, I am Canadian. Let's help folks understand the differences between the US healthcare system and the Canadian healthcare system, maybe focusing on some of what you see the positives and negatives in each one.
Yes, well, it's a daunting question to answer with someone who's an expert in comparisons of health systems, but I'll make a go at it from the Canadian perspective. You know, I think we have a lot in common. I think our challenges are similar as well. And, you know, sadly, both Canada and the US do not fare well when you look at comparator countries in OECD countries, for example, and you look at things like access to care or health outcomes or equity. You know, the only country that looks worse than Canada is the US. And so I think we both need to take a really hard look at how we do things, how we've established our structures, where we're spending our money, where we're prioritizing decisions, and look to other countries that are doing better, that are getting better value for money, that are getting the kind of health outcomes that people expect. You know, Canada has, of course, an amazing legacy that we're very proud of, the fact that everyone has access to health insurance for what's deemed medically necessary care, which sounds really fabulous until you kind of get into the underneath of that and realize that actually that definition of medically necessary care is pretty narrow, and it means that you have access to care for by doctors and in hospitals. In some cases more than that, but those are the only parts that are actually guaranteed.
Right.
You have access to those things based on medical need, not on ability to pay. But as probably most of the audience knows, care should not be delivered just by doctors. It needs to be delivered by a whole range of disciplines. And largely care happens in communities, not in hospitals. And if we don't do care in communities well, then people do end up in hospitals, which costs more money and doesn't always give the kind of outcomes we need. So, I think Canada has some things to be really proud of, thanks to decisions that were made 40, 60 years ago, but we haven't kept up in terms of being really creative and determined in terms of making sure people get access to the care they need.
Right. Are there aspects of the U.S. health system that you look at from the Canadian perspective and say, that's something we should try back home, or something that is worth maybe incorporating?
Well, no doubt there are all kinds of things that we look to the U.S. for in terms of leadership in health sciences. I actually think if I could wave a magic wand and integrate some health policy pieces from the U.S. to Canada, a lot of it actually would revolve around research. I think maybe you feel that you have, obviously there are always limited resources, but the kinds of investments from a national level in research and discovery science in the U.S. is really admirable. And we struggle with that in Canada. And so the whole world looks to the U.S. for that kind of investment in science, and benefits not all around the world, but widely in the world. The discoveries that happen in the medical sciences in the U.S. benefit people worldwide. Canada has not stepped up with that kind of investment, and particularly now that I'm thinking from the university perspective, to support the indirect costs of research in the way that the U.S. has. So there are a number of policy pieces that I think have made a huge difference in the advancement of health from the U.S. perspective.
And I think it makes a lot of sense to step all the way back and say, where are these health ideas coming from? And would you extend this same assessment to the more implementation or delivery research in terms of how we organize, or how Canada would organize its healthcare system? I read in your terrific report that Canada's reputation for being a country of pilot programs, but in order to make a difference, presumably these would have to be scaled. I'm curious, is there investment in that kind of research?
Well, I think that, again, I would say that probably both Canada and the U.S. lapse in our investments in implementation science. So if only we actually did all the things that we know that work, and when it comes to things like health systems, all of the stuff that we know and that this school has proven over and over again, if they were actually implemented in public policy, we'd be a healthier society. And when I say we, I'm talking North America wide in that case. But we often fail to actually get those discoveries in the policy and systems lens out to practice, not as well as we do in the clinical care implementation.
Right. You recently helped publish, I think, a fascinating report called Taking Back Healthcare, which is already an interesting title, right? Where is it? Why do we need to take it back in a country like Canada that really was one of the ones defining universal health coverage back 60 and more years ago? But this report is quite critical. It says Canada's falling short of population expectations, falling short of the human resource expectations, health workers' expectations, citing backlogs of procedures during COVID, very high costs, and real access barriers emerging in the country. If you were to describe the current health system and grade it, what grade would you give Canada's health system today?
So I would say, to answer that question, I would first of all try to take a little bit of a bigger picture perspective. You and I have both worked in countries with much less access to resources than Canada has. And so we shouldn't assume that we're doing poorly when you look at it from a global perspective. We should actually be doing better, though. So I'd give us a B, because I think we can do better. But there are billions, literally, of people around the world that would trade anything to have access to the Canadian healthcare system. So I don't want to be too harsh. Having said that, we don't have the kind of access that we should have, especially to primary care. We don't have the kind of accountability built into our systems in ways that we see in European countries, for example, where they, countries like Norway that have a right to care, right to health care built into federal legislation. So I think that we have a long way to go. We've actually recently had some data produced in Canada suggesting that about 22% of Canadian adults don't have a family doctor or a primary care nurse practitioner or any other front door to the healthcare system. And you all know what the results of that are.
And let's talk about family physicians, because they have been one of Canada's, I think, standout innovations and a huge source of pride and also investment. I like that you're calling them the front door. I think one of the challenges in any health system that I've studied is that connection between users, populations, and systems. How do we find our way in? And who can help us navigate also? Because of course it's incredibly complicated. You've written a recent op-ed about the shortage of family physicians in Canada. And you have some ideas for how we can try to address this. Can you just tell us a little bit about the situation with family medicine today, why it's reaching this crisis point, but also some of your ideas about how we can redress?
Sure. So, in fact, I've taken the analogy a little bit further recently. I used to always talk about family medicine or primary care being the front door to health systems. I think we actually need to consider it the first floor. And if you think about health systems as a house, we've done really well in Canada and the US on the second and third floors, right? State-of-the-art, incredible interventional medical technologies and, best in class of the world in the secondary and tertiary care. We didn't finish building the first floor first, right? So we didn't have a place where people could go, even though, again, there's been incredible research and policy in the US around patient-centered medical home, for example. So everybody knows how awesome that can be. But it hasn't been built universally. And so we have been doing a lot of work around what we can do to provide better access. But I think one of the things you and I talked about before we came on was what can medical schools do differently? Right. So I'm the director of the medical school in the Faculty of Health Sciences at our university. And we launched a really interesting project this year where we took some of our expanded seats in medical school and said, what if we actually had a cohort of the medical school that was specifically devoted to family medicine, where we actually asked applicants, and as you know, I'm sure like the schools here, there are thousands of applicants for hundreds of positions. And so we said, tell us if you really want to become a family doctor. If the reason you're going into medical school is to become a family doctor, tell us that in writing, and we're going to interview you with that lens. And we picked a unique cohort of students who are committed to family medicine. And they are at a separate campus with wraparound attention focused from family medicine, for family medicine, embedded in communities from the very start. And they have the ability to stream right from medical school into a family medicine residency. So I could tell you lots more about that, but we think it's an interesting innovation, has not been done exactly like that anywhere else in the world, and gets at some of the reasons why we are finding in Canada that fewer and fewer of our medical students are choosing to become family physicians. And there's a long list of reasons why that's happening, but this gets at least some of them.
Yeah. That's fascinating, actually. So it's an integrated path, right? They wouldn't be applying to residency separately. They're expecting to be going into family medicine residency directly.
Exactly, which is part of, for those of you who might be educators and sort of think about how curriculum works, there's a big chunk of the curriculum of medical school that happens in Canada largely in the fourth or final year of medical school that's dedicated to career planning and checking out all the different specialties and doing rotations through all the places where you might want to do your residency. If you actually extract that from the curriculum, you can start doing some of the advanced training that you might get in residency earlier in medical school. Build your comprehensive set of skills so that when you do get out to practice, you can do that full, comprehensive general practice that we need so much.
Right. And you mentioned earlier healthcare needs more than doctors, and I couldn't agree more. So tell us a little bit about care teams, and is that a concept? That's a concept we're looking at heavily here in this country, and really in every country that I work. The idea of extending the physician really bringing in a broader, often multidisciplinary team, but even empowering nurses, pharmacists, others more to take on some of these tasks to ease our access challenges, but also provide high quality care. So how would this look in Canada, or how is it coming along?
I'm glad you asked me about that, because it's one of these things that you think, why did it take us so long to figure this out? And even once we figured it out, why has it taken us so long to implement? I grew up I was a child in the 60s, and the old system was, doctors would graduate from medical school, they kind of hang up a shingle, hire somebody to make appointments for them, and they just start practicing. And I have colleagues that did that for 50 or 60 years. That does not work anymore. We can't build a world now where everyone has their family doctor that they personally will always get access to, and that's the person they will always see when they get care.
Right.
We can't train enough doctors to be able to do that, and it's actually not best for patients. So as you said, the evidence is there, proven over and over again, that primary care needs to be done in teams, that nurse practitioners, physician assistants, nurses, physios, OTs, dietitians, pharmacists need to be part of that team. I had a chance to practice in a team-based care model like that, and it's absolutely fabulous, because many times the dietitian provides better care than I do, or the physio will provide better care. So if we can attach people to a most responsible provider who will do their care for chronic disease management or preventative care, or build that relationship for long-term mental health care, but on a specific day that someone gets sick, they don't necessarily need to see their MRP. They can see somebody else who can get them what they need. And that primary care team can then also, be that hub for all of the other kinds of health-related services that people need to access, and be the place where everybody knows your name, and you can come home, to quote a Boston phrase.
I was just going to say, she's doing so well. She's only been here a couple of days and already Bostonian. Yes.
Exactly.
Wonderful. Thank you for that. So one of the aspects of your CV that maybe not as widely known is that in addition to being health minister, you're also Minister of Indigenous Services. And during that time, you were quite vocal about issues of access and quality of care among our Indigenous communities in Canada, including the racism that they experience, the steep health challenges, again, shared by many communities around the world in that same situation, opioid use and others. How is Canada's healthcare system dealing with these high-need communities with special needs, but also with a culture and a setting that requires recognition and respect?
That's just a short answer for that one.
Fortunately, we have,
we don't have much time, but let me tell you a
few.
few things about that. And I don't consider myself an expert on Indigenous health, but I did learn a lot when I was Minister of Indigenous Services. And, some of you will be aware of the fact that Canada has actually quite a terrible legacy of the way that we treated Indigenous peoples, the first peoples of our land, as people like my ancestors came and settled the land over the years. And when Canada was founded as a nation, it was founded in a way that actually tried to deny the rights of the first peoples of the land, that actually forced assimilation and domination of the dominant culture over Indigenous peoples. And that has had extraordinarily devastating effects on people's health. The worst government-wide policy that we had was a policy around what was called Indian residential schools, and there were other residential schools, and lots and lots of legacy related to that. I give all that background to say that the solution is to recognize that past, and and acknowledge that past, to acknowledge that truth, and then to reconcile and actually recognize those rights that were suppressed for so long. And one of those rights was self-determination, including self-government. And so one of the things that has happened over the years is that there was federal control over all health systems. It was an inferior standard of health, and still is largely an inferior standard of health. And so the denial of rights of Indigenous peoples is really at the root of all of those other things that lead to really poorer health outcomes. So lack of access to clean drinking water, lack of access to high quality public education, And the path forward on this is a hard one, and we've only just begun in Canada to do the work that's necessary to both recognize, respect, and implement the rights of Indigenous peoples. There are a few great examples of where we've done better in British Columbia, for example, where there's a First Nations health authority, where people do actually have autonomy over their own health systems, and we've already seen improved health outcomes through that. But that, I think, is the real pathway forward, is to be able to see First Nations lead health systems for First Nations and Inuit, for example, in order to see those health outcomes do better.
I think that sounds wonderful, and I think the tension may be, and how do we? I liked your point about standards, right? And what is a common standard of excellence, and a common high aspiration that is equally as high for Indigenous Canadians as other Canadians. And so in a system like Canada's, which devolves a lot of decision making to the provinces, I'm not sure if everyone's aware, but it's not so dissimilar from our state-based system in that sense. There are general rules, right, at the national level, but provinces do have quite some freedom in implementing. I guess one question to you is, how do we, in a system like that, and now adding some of these Aboriginal health systems, maintain those shared high aspirations, standards, while supporting the local solutions?
That's a fantastic question, and I believe, regardless of the particular constitution of your country, if you're going to be a country, there has to be federal leadership on health, right? So, we have shared responsibility or shared jurisdiction around health in Canada between the federal government, the provinces, and Indigenous governments. But if you don't have a federal government that establishes those kind of standards, and in Canada we did well with the Canada Health Act, which established 5 core principles under which money would be transferred to provinces for the delivery or operationalization of those principles. But we've lapsed on that. And I think in Canada, in order to do things like provide universal access to primary care, I believe it takes federal leadership and probably takes new federal legislation. And here's me telling you, who's an expert in this, but my understanding is that countries in the world that have the best access to care, or primary care specifically, it's most often based on federal legislation that establishes those standards, establishes mechanisms by which there will be accountability, and who holds that accountability. And unless that happens and is laid down in law at that level, I think it doesn't happen automatically.
No, I couldn't agree more. In 2018, we wrote a report on high quality health systems, and our starting point really in the findings and in the recommendations was high quality health systems is first and foremost a political decision, right? Followed then by a set of standards that is sufficiently high and motivating to orient the whole health system. And of course, there has to be that space for experimentation. But I think the notion of sort of leading by stepping back or letting the health system evolve is really an abdication of leadership, and leaves the health system in a very uncertain and a very weak place. So I think, but it is a challenge to implement both those shared standards and that local autonomy, as you've said. Let's turn in some of the minutes that we have left to thinking about what the pandemic has taught us. And I know that your country, Canada, has struggled as we did too, on so many different levels in terms of the population's trust and confidence in our health system, in our vaccines, and in so many aspects of the medical response, the healthcare response to the pandemic. But also on the supply side, on the healthcare side, health workers were burnt out. Health workers, reconsidered their career choices and their work-life balance and all of that. Again, a big topic we could probably spend a long time on, but can you tell us some of the lessons that you took away from the COVID pandemic for Canada's health system?
Again, there are many things one could say about this, but I tend to see the lessons based on where we didn't do as well as we should have. And I think that some of the choices that we made in Canada demonstrated values that are not ideal. So, for example, one of the areas where we really fell short was in long-term care facilities and congregate care settings, especially in the early days of the pandemic. To me, the choices that we made demonstrated our inclination to ageism and ableism in our culture in Canada, and that's a generalization because there are subcultures in Canada that are not so. But we made choices to put our PPE and our attention into hospitals, which were needed, in ICU settings, and it took a while for us to catch up to the fact that our most vulnerable citizens were living in places that weren't getting attention. And there's actually evidence that there was less medical care delivered in long-term care facilities during the pandemic in the early days than there was previous to the pandemic. So we made some big mistakes there, and I think that's something that we still have a lot of work to do on. I could go on with all sorts of other things. I think our approach to vaccines could have been different in a number of ways, as you see in retrospect. I've been thinking a lot about the art of persuasion and the way that you respect people's fears in a way that is not not putting people down, but actually doing what family doctors and nurses and many others have learned to do over the years, to listen to people's fears and work with them to gradually over time help people to understand why you are recommending vaccination. But we tended to kind of blast those who were either deniers or skeptics around science, and we've actually lost a lot of trust as a result of that, and that trust is going to take a very, very long time to re-earn. So many messages around vaccine delivery, but I'm sure many of you are looking into that as well.
We'll all be parsing, I think, as a world, many of those lessons for years to come. One aspect that I think everyone is newly intrigued with post-COVID is telehealth and the opportunities that may be there to extend access, to promote rapid connection with the health system. But also, as your report says, and as I worry about in my work, what are who's really going to be the super user of this telehealth? What conditions is it really applicable to? Are our elderly going to be ever comfortable with getting on FaceTime or on Zoom with their doctor? Or will they be relegated to kind of second order care where no one sees them? I'm curious your thoughts about the promise and peril of telehealth.
Well, I think you've captured a lot of it really well. Of course, it is a great tool in the armamentarium of what health professionals and teams need to be able to provide when it can be done safely. And so, what happened well in the pandemic was that we shifted the incentives so that people would get paid for delivering delivering virtual care. Some of those parts of Canada have shifted back, and so we're still rejigging a little bit, but it can't be isolated one-off. It can't be episodic care. It has to be actually delivered in that context of the primary care team, and that at an appropriate time for appropriate conditions by the appropriate provider, and ideally with a longitudinal relationship. That, of course, virtual care is a great option, but as you said, one has to always have an eye on who's benefiting from this and who's being left out.
Right. So we're running short on time, but we have lots of aspiring leaders here in this room, and I'm sure online as well. And I'm curious, just given your varied and impressive career, what advice can you give to aspiring health leaders, public health professionals? We've heard one piece of advice, which is go into politics, but what lessons from your own career and advice would you have for the next generation?
Well, maybe I'll adapt what I said earlier. It doesn't necessarily have to be politics, but I would say look for the levers. Figure out who's turning the dial, right? Because you all know that the structures that we have built over society were at some point built by someone or some people that established the rules for how we're going to organize ourselves. If someone made those rules, someone else can change those rules. And it takes a while to kind of figure out where you can get access to those levers, but look for them. There's nothing more frustrating than feeling like you don't have control, either as an individual or as a group. But you will be surprised as you go about looking for where you can actually implement change. Put your hand up and say, I'd like to help. Consider me. go ahead and start trying to get into positions where you can make changes. There is nothing more satisfying than being able to change the structures around you so that the people around you will be able to have better access to health.
Thank you, Dean Philpott, for being here today. It was really a pleasure, personally and professionally, to moderate this discussion. If you missed any part of this program or would like to rewatch it, a recording will be available on our YouTube page and our website. Join us next time on November 17th for a conversation with the former New Zealand Prime Minister Jacinda Ardern, and have a great afternoon.
Thank you.